8-year-old male. There is generalized periarticular osteopenia with loss of joint space in the proximal joints, in the carpal metacarpal joints, as well as in the carpal joints. I can't see any erosions. The distal joints appear to be well preserved. I can't see any associated soft tissue nodules or soft tissue components. So my primary diagnosis in this patient will be rheumatoid arthritis.
Okay, just hold on, please. I'll show you a better film, sort of a close-up.
Okay, so this is a zoomed image of the carpal metacarpal joints in the right hand and the proximal phalangeal joints in the left hand. I can see some juxta or periarticular erosions in the second and third digits in the proximal aspect. I can also see some osteopenia, some periarticular osteopenia. There's also loss of the joint space.
Right. So the point is that in this particular case, if you just concentrate here on this joint, this is the metacarpophalangeal joint. And see the joint space here, you will agree that the joint space is slightly reduced. And with that, you can see a marginal erosion. So the metacarpophalangeal joint is sort of affected. On the other hand, this is the proximal interphalangeal joint. And you can see on this digit, there is a bit of soft tissue swelling. Please remember that soft tissue swelling is a key thing to pick up in the exam. And that will be an indicator to look for something. Now, if you look carefully, look at this articular surface, which is slightly sclerotic, and you can see that there is a lucency here. We call it the dash dot pattern of early osteopenia or developing erosion. Similarly, you can see here that there is a bit of soft tissue swelling, and with that, there is a developing erosion. Now, pattern of the bony the joint involvement is very important. We can see that metacarpophalangeal joint is involved. We can see that proximal interphalangeal joint is involved. On the other hand, the distal interphalangeal joint is not involved. This is a key point for the exam. You did very well where you picked up periarticular osteopenia, and your differential was rheumatoid arthritis. What is other things which you will consider? Candidate 1, can you answer that?
So I'd consider, I may put chronic reactive arthritis in the differentials, because in the early phases you can get osteopenia, and possibly SLE, although it's not very specific. I wouldn't really have any other differentials.
Okay, excellent. So let us have an overview of this chapter, the major arthritis or the major problems which we will learn today. So as far as synovial is concerned, we'll see rheumatoid arthritis and then JIA. And enthesial, as in seronegative arthropathy, which include psoriatic arthropathy, chronic reactive arthritis, Ankylosing or Ankylosing spondylitis, enteropathic arthritis, and then degenerative, finally depositional, as in gout, CPPD, hemochromatosis. So we will see a lot of films from what has come in the exam and which can come in the exam. and what are the basic things to look for in the exam to be able to tackle a film. First thing is that this is an extremely important differential diagnosis in your book. Arthritis with osteopenia versus second one, arthritis with preservation of bone density. So whenever you tackle a film of this kind of a film, you have to tell the examiner it should be one of your pertinent negative or positives if there is osteopenia or not. Now, these are the arthritis which can cause osteopenia, including RA, septic arthritis, SLE. Look here, this is reactive arthritis, as in CRA, early phase. Let me go back to the next one, arthritis with preservation of bone density, and there is a huge group here, seronegative arthritis. Generally speaking, seronegative arthritis does not cause osteopenia. However, one of them, which is known as reactive arthritis or chronic reactive arthritis, can cause osteopenia in the early phase. So this point is important to remember. And if you go back to the basics, this is the list, chronic reactive arthritis. We'll come back to this, what is it? But right now, take home point is bone density is an important parameter to talk about in the exam. And bone density can be generally reduced or it can be periarticular reduction of bone density. So this should be your pertinent negative or positives. At times in the exam films, because of radiographic factors, it becomes a bit difficult. You can say that keeping that in mind, whatever your opinion is, and the examiners will correct you. They will not discredit you, but take home point is that this should be one of your pertinent negatives or positives and will help you classify the film into either of these two categories. Coming back to rheumatoid arthritis, many things, these are the 6 different headings which can happen in rheumatoid arthritis. First of all, soft tissue swelling. Look for this soft tissue swelling in your exam. That will be a parameter that the joint which has got soft tissue swelling might have an erosion. So this is what you are talking about, marginal erosion. And there can be osteopenia and there might be localized osteopenia. Periosteal reaction is quite rare in rheumatoid arthritis, and it is much more common in other type of arthritis like psoriasis. And when arthritis is full blown, then you can have a lot of deformities. I'll show you. Of course, secondary OA changes can happen, but the key finding is marginal erosions, which you have to develop your eyes. So this gives you the pattern, and this pattern is a take-home point for today. Particularly look at the hand. Hand is the favorite for the exam. And in the hand, you can see that the metacarpophalangeal joints are involved and the proximal interphalangeal and the distal are not. This is a key point. Of course, the carpal joints can also be involved. In the foot, the red dot means more common involvement and the yellow dot means less common involvement. So the 5th metatarsophalangeal joint is very important to remember. Of course, others can also be involved, but the 5th is very important to remember. Rheumatoid arthritis basically can involve any joint of the body, even TMJ and things like that. But these are the exam type of things which you have to remember. Cervical spine is again exam, and I'll come back to show you a few films. So if you can concentrate here, and this will help you what happens in rheumatoid arthritis. So this is a joint, joint capsule, articular cartilage, and then it fills up with inflammatory material, and there is swelling. And then if you see here, there is development of osteopenia. And with that, this articular cartilage, it might be thin and it start developing that dash dot type of a pattern. Then marginal erosions will happen. You see this marginal erosion. And classically, if you go back to your anatomy and see if this is the metacarpal or if this is the proximal phalanx, this is the capsule. This area is known as the bare area, B-A-R-E, as a naked area. And classically, erosions are here, first of all. So this is the bare area, and bare area is larger on the proximal aspect of the joint. This is arthritis mutilans type of picture, where what has happened is that there is a pencil and cup deformity. And this film has come in the exam quite a few times, and they will ask you what can be the differential. We call it arthritis mutilans. I will show you. Now, just to develop your eyes, early signs. If you see here, just concentrate on the soft tissue swelling. Look here, there is a soft tissue swelling. So develop your eyes to pick that up. Now, early erosion at the bare area. So this is classical. And so this is a bare area. Another erosion here, if you can see here. Another erosion, and now look at the joint space. The joint space has also reduced, soft tissue swelling is there. Okay, candidate 1. This is a known case of RA. Can you describe your findings for everybody?
Okay, so this is a radiograph of both hands in a skeletally mature patient. I can see periarticular osteopenia predominantly surrounding the proximal interphalangeal joints. There is soft tissue swelling as evident in the left second metacarpal phalangeal joints bilaterally. The distribution is rather symmetrical, affecting both hands. I can see some periarticular erosions in the second and third metacarpal interphalangeal joints. There is loss of joint space predominantly in the proximal interphalangeal joints bilaterally with a symmetrical distribution. And there's also ulnar deviation of the right hand.
Where is the ulnar deviation of which joint? Right.
Is it the metacarpal joints? They appear to...
This is the carpo-metacarpal. Not very convincing, actually.
Okay.
Okay, that's fine. Well done. Now, okay, another case for you, candidate 1.
Okay, this is a radiograph of both hands in a skeletally mature patient. The bone density appears to be preserved. There is acroosteolysis of the terminal tufts bilaterally in the second and third digit on the right and on the third and fourth digit on the left. There is loss of joint space predominantly in the proximal interphalangeal joints bilaterally with subchondral sclerosis. I can also see some periosteal bone formation in the right, second, third, and fourth proximal phalanges, and also on the left in the first proximal phalanx. I can't see any significant soft tissue swelling. My primary diagnosis would be psoriatic arthritis, given the terminal tuft erosion with periosteal bone formation. Gout could be a possible differential, given that it's predominantly a distal phalangeal joints
So if you see these joints, you know, this distal row, interphalangeal joint, do you think they are involved?
No, not really.
So anything else can explain this finding? You have picked up brilliantly. Well done. Acrosteolysis.
Hyperparathyroidism can cause this.
Excellent, excellent. Well done. So anything else to any other stigmata of hyperparathyroidism?
Yeah, there's subperiosteal bone resorption of the right, second, and thirds.
Excellent. I'll take over. Well done. So this was a trick film. You know, trick film, there was a purpose. We know we are doing arthritis, and I have put a film of hyperparathyroidism just to give you some point to remember for the exam. Please remember, in the real world, this is not going to happen that you are in arthritis. So basically, what you have to do is you have to develop review areas for each and every film. And hands, and there are so this is a film of hyperparathyroidism. Actually, what happens in hyperparathyroidism, that there is all kinds of resorption of bone, and we will cover hyperparathyroidism on this Saturday. But there is an entity, we call it subperiosteal bone resorption. When there is subperiosteal bone resorption, the outline of the periosteum, it occurs fuzzy and indistinct. There is another type of bone resorption which is shown here, and this is known as intracortical bone resorption. When that is there, the outline of the periosteum, it remains very sharp and distinct, and we also call this phenomena as cortical tunneling. So if you see here what is happening, this is classical finding, absolutely classical exam finding of hyperpara, where the radial side of this phalanx, you can see this ill-defined fuzziness, and here also, and here also, and here also. And with that, you can see it particularly well on this one, where you can see this crisp and sharp. So this is intracortical or cortical tunneling. So this is hyperparathyroidism, and with that, we can see acrosteolysis. Please remember that bone density, if it is increased, it might be increased in this case, that might go with renal osteodystrophy. In any case, we'll come back to this film on Saturday. But the take-home point is that for each and every film in your exam, you have to develop a review areas, and your eyes should be searching for specific abnormality. And this formula is very important for rapid reporting also, and for Viva films also. That you start looking at joints, you start looking at specific things. The eye see what the mind knows. So that is critical. Well done. Periarticular, what we call osteopenia, beautifully seen in this film. You can see a lot of it in multiple joints bilaterally. Again, from literature, osteopenia and some erosions. On MR, I'm not expecting that anybody will show you an MR of rheumatoid arthritis, but you can make up your radiology if you know the basics. That on a T1 weighted sequence, you can see erosions, and you might, if there is edema, you will see low signal on T1 and high signal on STIR. There is a rupture of this, the scapholunate ligament here. Okay, so let's develop our concepts on the type of deformities which you can see in advanced cases of rheumatoid arthritis. And these words are important for you for your exam. So this is a cadaveric X-ray. This is the cadaver. And you can see that this is known as the swan neck deformity. So the proximal joint is in extension and the distal is in flexion. This is swan neck deformity. This is boutonniere's deformity, where there is flexion of the proximal and extension of the distal. And this is what we call ulnar deviation. And this will happen in advanced RA, where you can see metacarpophalangeal joint, and there is subluxation and there is deviation to the ulnar side. These three words should be in your vocabulary when you are tackling a case of arthritis mutilans, which is an exam case, though a very easy exam case, but the main thing will be the viva on differential diagnosis. So here you are, arthritis mutilans, and you can see various kinds of deformities and these ulnar deviations, etc., at multiple joints. So this is ulna, and you can see how there is collapse of all the carpal bones, etc. So arthritis mutilans, this is the differential diagnosis, 3.8, page 50 in your book. And these are the common causes, these are the less common causes. And at least you should know the common causes for your exam. In the present Chapman edition, if you see carefully, in each list, some of them have been underlined, and anything which is underlined means that this is important for your exam. If you forget this, fine, but at least for your exam at a registrar level, you must tackle these. Okay, candidate 1. This is your last case. Over to you.
Onto radiograph of both feet in a 54-year-old female patient. In the fifth distal metatarsal joint bilaterally, there appears to be some periarticular erosions.
Yeah, just to stop you, because this was not included, I have given you a close-up here for the fifth on this side, the left side. Over to you. Sorry.
And the erosion doesn't appear to have a sclerotic margin. There doesn't appear to be a significant soft tissue component. There is loss of joint space in the second metatarsal phalangeal joint and also the proximal phalangeal joints bilaterally. There's also periarticular erosions, so periarticular osteopenia.
Okay, what is your conclusion?
And a hallux deformity of both toes. So my primary diagnosis would be rheumatoid, or gout. However, I favor rheumatoid because the erosions do not have a sclerotic margin. So my primary diagnosis would be rheumatoid arthritis of the feet.
Okay, well done. So the take-home point here is that as far as the metatarsophalangeal joints are concerned, you have to keep a few things in mind. CRA, as in chronic reactive arthritis, also involves it. And so that can be in the differential diagnosis. Unusual for a 54-year-old with CRA. Gout should be kept in mind. Gout will not be, it's sort of a bilateral symmetrical type of appearance. So gout is not bilateral symmetrical. And second point which was made was about the sclerotic margin of the erosion, which is quite pathognomic for the erosion of gout, and we will see it shortly. So, okay, well done. You can please mute your self. Okay, let me mute you there.
Thank you, I can do it.
You can do it, yeah. You can mute yourself. So, rheumatoid arthritis we have covered, and the joints in the hands we have covered. In the feet, particularly the fifth one, is important. Another film which can come in the exam is stigmata of RA with a rheumatoid nodule. So please remember, that if you don't know it, then you will be surprised what's happening. And you might say that this is a tophi of gout, for example. So please remember that rheumatoid nodules can occur or happen, and these things can project on the films also, as in this case from literature, where it is causing scalloping. Arthritis with soft tissue nodules. So remember RA, remember gout. There are other things here, but these are the top two which you have to remember. Okay, candidate number 2, if you can raise your hand, please. Okay, we'll come back to you if you maybe there is a technical problem or something. Candidate 3, if you are listening, can you raise your hand? Okay, 2 participants have raised hands. Candidate 3.
Yes.
Okay, you can. So if you can please tackle this film, a very, very good FRCR2B film, though the quality is slightly, suboptimal, but it's a very good film. Over to you.
Right, so this is a frontal radiograph of the right shoulder of a 61-year-old female, showing marked deformity of the right shoulder joint. The humeral head is cranially displaced. The image is a little bit unclear, but there is osteopenia in the proximal humerus. There is also osteopenia in the lateral scapula. The joint space is unclear, but I think there are some erosions in the articular surface. So my differential diagnosis is maybe Milwaukee shoulder, maybe Charcot joint. These are my top differential diagnosis.
Why do you say Charcot joint?
I can see deformity, I can see osteopenia.
So Charcot is without osteopenia, by the way.
Right, yeah. So maybe septic. Right?
Can I ask you a question? Where is the clavicle? Do you see the clavicle?
No, I can't see the clavicle.
Right. So can you make up your final conclusion then?
Maybe it's traumatic, like a sequel of old trauma. Or maybe it's some sort of syndrome, and this is like the sequel of syndrome at the age of 61. Really sure.
That's fine, I'll take over. Thank you. Well done. So if you see here, this is a case of advanced rheumatoid arthritis. First of all, if you go back to your differential diagnosis, erosion or absence of outer end of clavicle, and top 3 are post-traumatic osteolysis, post-operative, and rheumatoid. And then less common are all of these. If you remember, we have already done these 3, dysplasia, these 2, cleidocranial dysplasia and pycnodysostosis in the first chapter. Now, this is a case of advanced RA, rheumatoid arthritis. So what happens is that basically there is superior migration of the humerus in relation to the glenoid. So when that happens, and that also tells you that the rotator cuff is completely torn. With that, where is the clavicle? Ask yourself, where is the clavicle? And then you realize it's missing. Of course, in the exam, you can ask this question that is there history of any surgery? That's a legitimate question. But having said that, with that, what happens is that this is because of mechanical effects, where the inferior surface of the glenoid is causing chronic indentation. So this is a very important exam film, and this has come in the exam of rheumatoid with, and the clavicle is the key finding there. Okay, again your case. Concentrate on C1 level.
Right, so this is lateral plane radiograph of a cervical spine of 71-year-old female, multiple joint pains. I can see increase in the distance between the anterior arch of atlas and the dens of axis.
Excellent. Can I stop you there? So this has been pointed out. This is the anterior arch and this is the dens, and this distance is increased. In the exam, of course, you can ask the examiner that I want to measure it. If they want you to measure, they will ask you to do it. Otherwise, they will simply agree with you because they have got limited time. Having said that, candidate 3, what is your conclusion?
My conclusion.
The causes of this increased distance at this joint.
It's maybe ligamentous affection at this region, and this is one of the important findings of rheumatoid arthritis.
Okay, well done. So what is the distance, by the way, in an adult? How much? Normal?
I think the maximum is 4 or 5 millimeters.
So in an adult 3 and in a child 5. So remember, in a child more leverage is allowed. You have to remember this. Now, just to go back to your anatomy, this is the normal, and you can see that this distance has increased. Now, what has happened after 6 years? Over to you. What do you think has happened? Same case.
Alveolar invagination.
Okay, so can you describe the findings for me?
Okay, so I cannot see the dens on this lateral projection, which is quite unusual because it's mostly concealed or shadowed by the mastoid bone.
So your conclusion is, as you have already elaborated, what word did you use? Basilar?
Basilar invagination.
Invagination, okay. Good. So if you see here, this is an extremely important exam case, and I will show you a few other, concepts around it. Now, what happens is that this is dens, and this is the arch. And here, what has happened? The dens has gone into the foramen magnum. Candidate 3, can I ask you, what do you think has happened? Why has it gone in? And the patient is a known case of RA, you are right. What has happened?
Yeah, possibly the laxity of ligaments and then the weight of the head led to the downward migration of the head over the spine, and possibly some the osteopenia, and might be some osteolysis also of the dens, maybe.
Okay. So if you see here, this is another patient. This is a tomogram, old tomogram, where you can see that the dens has gone into the foramen magnum. So what is the concept behind it? This is the tomogram. Of course, your generation does not see tomograms, which is obsolete now. But having said that, just to make a point that if you see that this is dens and this is the lateral mass of C2, where is the lateral mass of C1? And there is no lateral mass of C1, and this is what happens. So if you see here, normal anatomy is this one, where this is dens, this is lateral mass of C2, this is lateral mass of C1. And in rheumatoid arthritis, what happens is that just like there can be erosions of the dens, there can be erosions of this lateral mass. And look at these two examples. Here in this example, on the left side, you can see that the lateral mass is slightly eroded. Another example, and here you can see more erosion of the lateral mass. Look at this, and then look at this dens, which has got erosions, and even here there is a bit of erosion. So what happens is that because of that, there is superior migration of the dens into the foramen magnum. You can well imagine, if you go back, stretch of imagination, this is the clivus. You can imagine that the brain stem, the medulla, must be sitting here. And this dens is projecting superiorly. And that is why if you Google it and read a few case reports from surgical literature, you know, there have been deaths in clinics where a clinician will ask a chronic RA patient to bend, and these studies might be 30 years old or 40 years old, and they just die. And this is why anesthetists also, they are very careful. They do radiology with before any, you know, intubation. You can well imagine that it can also cause the sudden death of a patient. So this has come in the exam quite a few times. In my life, I have seen 3 such cases. So it's rare these days, but you have to keep your minds open. And you have to also keep this in mind that there are other things which can cause the same radiological finding. So what are the other things? Now, look at this from your Chapman, 13.52, platybasia and basilar invagination / impression, congenital and acquired. Now, in the congenital, osteogenesis imperfecta is very important to remember. And this has come in the exam. I've shown you previously. I'll again show you once again. But look at the acquired ones. Basically, in the acquired ones, what is happening, either there is destruction of the bone or the bone is soft. Why will it be soft? For example, Paget's disease, osteomalacia, hyperparathyroidism, and there is invagination. And in localized bony destruction, you know, things like metastasis, TB, etc. can cause this. There is a bit of overlap in literature, and some of the old literature uses this term atlantoaxial impaction. So don't get confused. This is similarly similar to what I showed you in this RA case, atlantoaxial impaction. So so these are the definitions from, but this word is not given in Chapman. So this word should also be in your vocabulary so that you don't get confused. Look at this case. I showed you this case, a beautiful case. It has come in the exam. And here what is happening? What is happening? This patient has got osteogenesis imperfecta. And there is invagination of this cervical spine, you know, superiorly into the foramen magnum. And there is, you know, this bulging of the temporal bone and the occipital bone. Very unique appearance. And this patient also had stigmata on other bones. This appearance in literature is known as Tam O'Shanter skull, and another sign which is in literature is floppy head sign. And this is given in literature both for osteogenesis imperfecta as well as Paget's disease. So important exam case. If you know it, you will pick it up. Otherwise, you will always get confused because the examiner is going to start with an AP or a PA skull fill. This is the concept that if this is the McGregor line from the heart palate, and this thing should not be, upper border should not be more than 5 millimeter. If more than 4.5 millimeter, it is basilar invagination. This is the definition. Okay, candidate 3, your film.
Right, so
What do you?
these are selected sagittal but then these signal in the anterior arch of atlas, as well as the dents on.
Can you speak, your volume is a bit low. If you can speak a bit loudly, please.
Oh, all right, this is better.
Now it is perfect.
Okay, so I can see high T2 signal in the anterior arch of atlas and in the dents. I can also see some high T1 signal related to the tip of the dents. And I can see that the cord is
Is there invagination or impaction?
Yes, there is. And there is narrowing of the spinal canal too.
Okay, if you see here, what is happening that this has gone up. This is the foramen magnum, this is the pons, this is the medulla. It is sitting up there. And what is the cause? So I can also, as an examiner, show you, let's say, an axial sequence. If I want to show you, I will show you an axial sequence here. Basically, candidate 3, just tell me, just on this sequence, what is abnormal?
The dens is not central in its normal articulation position.
And
I can see the dens at the same level of the skull base bones.
Excellent. So you can see that this becomes a very good exam film on an axial, where the examiner will open it and you have to pick it up that this dens should not be projecting into the foramen magnum. And if you see these, now you can understand what has happened in this case. Look at the lateral mass. This lateral mass has also subluxed. But on this side, there is no lateral mass. It is all destroyed. So similar finding to the RA finding, even more blatant. And this patient was only 29-year-old, and this is TB arthritis, which has caused this. So feedback forms, of course, I will project in the break, and you can, those of you who have got a mobile phone, you can use this. Otherwise, you can use this URL. Another example where this patient has got metastasis from melanoma, and you can see multiple metastases in the spine. But look at the foramen magnum and see how the dens has gone superiorly. So apparently the melanoma metastasis must have destroyed the condyle, or either the occipital condyle or the the lateral, what we call mass of C1. Okay, candidate 3, your fill.
Right, a 4-year-old female with multiple joint pains. So these are frontal and lateral plain X-rays of the widening of the joint space.
Your mic once again, please.
Oh, sorry, yes.
Better.
Okay, I can see some articular irregularities.
Okay, just concentrate on the epiphysis. Compare the epiphysis right and left.
Okay, so the epiphysis on the left side is bigger and is enlarged and less dense, and I think there is some articular surface irregularity.
Okay, so what is your conclusion? 4-year-old multiple joint pains. What do you think is happening?
Maybe it's juvenile arthritis.
And why do you say that? How do you explain this enlarged epiphysis or asymmetrical epiphysis?
I'm not really sure, but maybe it's from the inflammation and the hyperemia and the synovitis.
Okay, well done. Excellent. So, candidate 3, you can mute yourself now. Now, if if you see here, JIA is an extremely important exam film. And again, the eye see what the mind knows. One of the findings in JIA can be that because of hyperemia, there is accelerated growth of the affected epiphysis. And then there can be premature closure of epiphysis also. The same case, they might show it to you at the age of 20, 21, when the epiphysis has closed. And that I will show you shortly. So that also becomes a very important exam film. Here what has happened, that if you see this epiphysis and compare it with this one, this is bigger as compared to that. Look at this one, it is bigger as compared to that. Look at the lateral and look at this patella versus this patella. So how can you explain this? JIA. Now, JIA or juvenile idiopathic arthritis, clinically speaking, is a huge subject. I don't want to go into that. But basically for the exam, when a patient becomes a teenager, etc., the findings of, let's say, erosions, etc., can also be seen just like the adult pattern. But before that, the two things you have to keep in mind. One is this finding, where enlarged epiphyses are there. And second thing is periosteal reaction. So I will show you a few films. Now, is candidate 2 with us? If yes, raise your hand, please. Okay, candidate 2, can you hear me, please?
Yeah.
Okay, so this is a case of JIA. Can you please tell us your finding?
Okay, so this is a frontal radiograph of both hands for a child. The picture's not the best, but I think that there is almost bilateral symmetrical periosteal reaction.
Yeah, don't worry about it. There is no reaction. So I understand that the the radiographic factors are not there. Anything else considering JIA? Can you compare right and left? Look at the epiphysis, compare it.
So on the right, there's some soft tissue swelling and enlargement of the metacarpal epiphyses, probably most in the index and middle finger metacarpal epiphyses.
Okay.
With some soft tissue swelling around the index finger.
Okay, excellent. I'll take over. Now, if you see carefully, the first finding is, look at this, develop your eyes on this soft tissue. You compare this soft tissue to this soft tissue, and one can appreciate that this soft tissue is more. Then look at the epiphysis, and this epiphysis is larger as compared to the other one. Look at this epiphysis, and this is larger. A subtle finding, but considering what we have learned in the previous case, this is what I say, the eye see what the mind knows. So in JIA, look for the epiphysis. Well done. Now, just to make a point that sometimes in JIA, particularly in teenage, etc., or early teenage, late teenage, you can see findings of erosion, etc. also, just like adult. Nobody is going to show you this in the exam. If they want to show you in the exam, they will show you this in enlarged epiphysis or what we call periosteal reaction. This is a T1 weighted sequence, which also tells you how beautifully erosions can be seen in any condition, for example, JIA or anything, or like RA, etc., and you can see on this T1, you can pick it up. Studies have told us, of course, MR is up there much better than plain film, but that doesn't mean that everybody is doing MR, and that also does not mean that they are going to show you MR. Classical exam film. Over to you.
Okay, so this is a frontal and lateral radiograph of the knee for a 23-year-old female. There is widening of the intercondylar notch on the frontal radiograph with moderate to severe degenerative changes, particularly in the lateral tibiofemoral joint. In addition, on the lateral radiograph, there's probably some degenerative changes around the patellofemoral joint also. On the first image, there looks like there's some erosions around the lateral femoral condyle, which is also smaller than the medial side.
What's happening to this thing? What is
So
this?
that's widened, the intercondylar
Right.
notch.
Okay, so conclusion. This is a 23-year-old female.
So in summary, there's these findings would be in keeping with a history of either juvenile idiopathic arthritis or a history of hemophilia.
Okay, so female hemophilia.
No, male.
Here you are. So that was a catch, and it has happened in the exam. Please remember, I'm showing it to you for a particular purpose. This is a classical, very favorite film where they will show you some young, particularly on knees. And this also is what we call rather a story film. Story films are extremely important for your 2B exam. Story film is a film which tells you a story, simple as that. And something has happened. So what has happened that there was a hyperemia. So the concept behind it is that when there is joint hyperemia, there can be accelerated growth of the epiphysis. There can be premature closure of the epiphysis, and which will produce a bit of deformity. Widened intercondylar notch is because of hyperemia, and there is erosion of the bone. Now, the classical thing is that they will show you a young adult, maybe in the 20s, and the differential diagnoses include JIA and hemophilia. Hemophilia, of course, will occur in males. So this thing, if the examiner, what is the take-home point? I have written it in a PowerPoint mode, but please remember in the exam what will happen. The examiner might tell you in the beginning of the case that this is a 23-year-old female, and you might not concentrate on the word female. So please remember, anything which the examiners say might have a very, very important meaning. So enlargement, this is first differential diagnosis, enlargement of the distal femoral intercondylar notch, JIA and hemophilia are up there. There can be so many other causes. And this is a differential diagnosis 14.3, premature closure of growth plate and local hyperemia, JIA, hemophilia up there. There is another one, which is asymmetrical maturation, 14.4. And again, chronic hyperemia, as in JIA and hemophilia, is there. And then look at this film. Again, I tell you that these kinds of films have, extremely important for the exam. Bilateral knees. And if you look carefully, there is asymmetry between the two, but on each side, look at this epiphysis. This is larger as compared to this. Look at this notch, which has widened. These are secondary changes, right? on this side, this is larger as compared to the left, but not as large as this side. And so this is a 22-year-old male with JIA. This is a film of hemophilia. Now, of course, if you look carefully, some of the things are visible. This epiphysis is larger. You can see widened intercondylar notch. These are secondary changes, so we are not very interested. But on a plain film, they say, literature tells us that one of the findings is that there is increased soft tissue density, as in this increased soft tissue density because of chronic hemorrhage. I will take this finding with a pinch of salt, but it is given in literature. So that's why I am showing you. This is the only way to differentiate between the two. If it is a male patient, young male, otherwise the radiology might be very similar. Candidate 2, over to you.
Okay, so these are zoomed in images of the hands for a child patient. I think these show periosteal reaction at the lateral aspect of the proximal phalanges, fairly symmetrically. Looking
Excellent,
at the proximal.
excellent. I'll take over. Well done. So if you can see here, periosteal reaction, periosteal reaction, periosteal reaction, periosteal, periosteal, periosteal. What can be the cause? Over to you, candidate 2.
So I recall that it could be normal in a child. Other differentials could still include JIA. Things like rickets.
Okay, so if you see here, this is, you remember when we were doing the first chapter, or the second chapter, we went through the differential diagnosis of bilateral symmetrical periosteal reaction in a child. And the key thing which I told all of you, that in the exam, you have to tell the examiner the differential diagnosis in that case, the case which is shown to you. And you cannot, from the differential diagnosis, the examiners, they use this word. I have talked to them many a times. They use this word, do not regurgitate Chapman. Means that you remember it and you just go through the list. You have to tell them on that particular case. So please remember, in this particular case, you cannot say a few things. For example, look at the epiphysis, and this is not a young child, as in an infant or a neonate. So this normal infant cannot come in the list. Of course, rickets is, that's a pseudo finding. We covered it in the past. Will not involve the small bones of the hands. Small bone of the hands, if you ask me, it cannot be acute leukemia, it cannot be rickets, it cannot be this, 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 nothing. And because the age of this patient is slightly, it's not an infant as in, or a neonate. So that's the key. And things like pachydermoperiostosis, which can happen, let's say in a teenage patient, we'll see it later today, that might be kept in mind. I think nothing else. And for counter argument against that will be that usually those patients are much elder than this. So we will now take, let me, candidate 2, I'll give you one more film, which is this film, and then we will take a 5-minute break. Candidate 2.
Okay, so this is a frontal radiograph of both hands for a 52-year-old male. There's an abnormality bilaterally affecting the distal interphalangeal joints where there is erosion of the distal end of the middle phalanx and subsequent degenerative changes. This is reasonably symmetrical, probably slightly worse on the left. These findings would be in keeping with an erosive arthropathy.
Your differential, please. Well done.
My differential for this would include rheumatoid arthritis.
So my question before you continue, distal interphalangeal joint involvement. Does RA or no?
Not for the distal.
No. Okay, well done. Just give me a bookish differential diagnosis for distal interphalangeal joint involvement in the hand. Bookish means not in this case, but for your exam, which three conditions should come to your mind if distal interphalangeal joint is involved? Do you remember?
Psoriatic arthropathy.
Excellent, well done. Number two.
Lupus.
Okay, it can involve, but I'll not keep it in the top three.
Okay. Sorry, no others are coming to my mind right now.
Okay, well done. You can mute yourself. Thank you very much. Now, first of all, take home point for the exam. Distal interphalangeal joint, always remember three things. First is psoriasis. Second is erosive OA. Erosive OA is a particular entity, I'll show you.
Yeah,
and the third thing is gout. Gout will, otherwise RA should not be. Now, if you look carefully, you can see these erosions which are practically involving whole of the articular surface. Look at this one, the pencil and cup type of deformity. And so the distal joints are involved. And so this is psoriasis. And we will take a break now, and it's going to be a 5-minute break. Thank you very much, candidate 2. me give you the overview for the exam as far as seronegative arthropathy is concerned. You remember the list that the list includes psoriasis, CRA, angstphon, and IBD, etc. The hallmark of seronegative arthropathy is enthesopathy. This is a take-home point. What does that mean, enthesopathy? Basically, there are changes at the origins or insertions of ligaments and tendons. There can be erosions there in an acute phase, and later on there is new bone formation. So that is also a hallmark, new bone formation. And if you don't know it, many of the things you are going to confuse. Pattern of the joint involvement is important because this is how the examiner will see your thinking. How can you differentiate between a psoriatic arthropathy and CRA, for example? Usually, bone density is maintained, so there will be no osteopenia, except in CRA in acute phase. Please remember that previously, CRA was also known as Reiter's or Reiter's, whatever you want to pronounce it, syndrome. We don't use this word now because the concept is that initially we used to think that CRA can only involve males. And you remember the classical definition was urethritis, conjunctivitis, and arthritis. Later on, we have discovered that CRA can also involve females, and for them cervicitis, as in inflammation of the cervix, replaces urethritis. So sometimes in CRA in acute phase you might not get osteopenia. Otherwise, you will get osteopenia. Similarly, sometimes in advanced ankylosing spondylitis, you might not get any, you might get osteoporosis, and this is because of disuse. But usually in angstphon, you don't get it. Now, other than that, you can get soft tissue swelling, marginal erosions, etc. So with this background, let's take it further. Okay, one point is that in psoriatic arthritis, look at the hand. Psoriatic arthritis, you have to differentiate it with CRA. And one of the take-home points will be the, just 1 second. One of the take-home points will be the differentiation between involvement of hand versus the feet. Take-home point is that in psoriasis, hand is more commonly involved, and in CRA, feet are more commonly involved. Rest of the pattern in the spine and the SI joints, they remain the same. So this hand versus feet discriminator is an important thing. So this is psoriatic arthritis. You can see involvement of the distal interphalangeal joint. You can see new bone formation also, which is, look at this one. This is known as a sausage digit. You can see a lot of soft tissue. You can see this periostitis or periosteal new bone formation. And this is against arthritis mutilans. You can well imagine, clinically speaking, if you examine this case, there can be what we call telescoping. You can actually increase the length because there is no joint here. Now, please remember that if you see periostitis as in periosteal reaction, top of the list should be psoriasis. And this is the differential in your Chapman, arthritis with periosteal reaction, and seronegative arthritis is the most common, and out within that, PSA is the most common. Candidate 4. Candidate 4, there is a sound which is coming when I unmute you. I don't know what's happening. Now, can you speak, please? Let's see if it is working well.
Okay.
Yeah, I can. There is a very. In any case, over to you. Let's tackle this film. But there is some technical problem because of which we can hear a sort of a irritating type of a sound. In any case, please continue.
Okay. So I'm provided with a dorsal palmar view of the both hands of a skeletal mutual patient, in which I can see there is a involvement of the distal phalangeal joints symmetrically, involving the both sides more marked, and there is a decrease in the joint space as well. I want to look for the soft tissue swelling, so I can also appreciate the soft tissue swelling in the right index finger proximal region. And what else I can see? So rest of the metacarpal, carpal and metacarpal joints are normal to me. So, and there is a subluxation is also noted in the distal interphalangeal joints.
Okay, just concentrate on the distal interphalangeal joint, and whatever you see, can you conclude your film on that basis?
Okay. So there is a central erosion noted in the distal interphalangeal joints, along with the soft tissue swelling, more marked on the right side, but and giving the seagull appearance. So my first differential will be erosive arthritis or psoriasis.
Well done. I'll take over. Now, this is erosive OA. And in erosive OA, what we see is what we call the gull wing sign or the seagull sign, whatever you want to call it. Now, please remember, whenever the distal interphalangeal joint is involved in the exam, you have to consider psoriatic arthropathy, erosive OA, or of course, that will be radiologically speaking different, gout. If you see, this is psoriasis, where you can see that there is an erosion which is involving whole of the surface of the articular surface. Here, what happens is that in the proximal portion, there is a central erosion, and then there is proliferative change which fills it up, and it gives you this seagull sign or gull wing sign, whatever you want to call it. And clinically speaking, this is how this patient will present to you with what we call Haberden nodules. Now, OA, of course, can involve many joints, but remember for the exam, erosive OA, which involves the distal interphalangeal joint. Now, candidate 4, this is psoriasis. What are the findings as far as is concerned?
Okay. so that's the lateral view of the ankle joint and the cone view of the calcaneum, in which I can see there is erosion at the posterior part of the calcaneum at the level of the attachment of the Achilles tendon. So I can see there is erosions involving the upper part of the calcaneum. I want to look for the soft tissue swelling. So yeah, I can no spur form.
What is this?
That's the Achilles tendon attachment and erosion. So as this known psoriasis, yes. So it's an enthesopathy.
Okay, excellent. Well done. So what happens, and you have to develop your eyes on this, that what will happen that initially when there is acute change, there can be erosion here. Then there can be what we call new bone formation in the soft tissue at the site of ligamentous and tendinous insertion. So this is enthesopathy and vis-a-vis Achilles tendon. If you see this case, okay, can you tackle this? Over to you, candidate 4.
Okay, that's the 31-year-old male, low back aches. That's the frontal projection of the hip joint and the cone view of the left sacral region, in which there is involvement of the yes, I can see there is a sclerosis of the left-sided sacroiliic joint.
Okay, you have picked up sacroiliitis, bilateral asymmetrical, more marked on the left side. What else? Anything else?
So I can also appreciate there is enthesopathy involving of the left lateral part of the sacrum, anterior superior iliac spine region.
Okay. What is your conclusion?
So, as is the asymmetrical environment, so psoriasis will be the first diagnosis, or it could be reactive arthritis.
Okay, we stop there. Well done. So here we can see that there is bilateral asymmetrical sacroiliitis, and with that, this is enthesopathy. And you have to develop your eyes that there is new bone formation at wherever the muscles are attached or the ligament. Can be, as say, this differential diagnosis, extremely important differential diagnosis for the exam, sacroiliitis. Now, in sacroiliitis, what happens is it can be bilateral symmetrical, it can be bilateral asymmetrical, and it can be unilateral. So, Angstform, for example, is bilateral symmetrical. I want to warn you about these two. Hyperparathyroidism has come in the exam many a times. And if you see here in Chapman, they have mentioned this word mimic. I will explain to you what happens. Osteitis condensans alii is very important for your day-to-day reporting. It is not as important in the exam as for your day-to-day reporting, that you should have this concept, what it is. Asymmetrical CRA and PSA, both of these can be considered. Now, look here. This is classical osteitis condensans alii. These patients are youngish, maybe 30 years old, 35, 40 years old, will have a lot of sclerosis on the iliac side of the joint. They will be multiparous. So basically, because of the strains of parturition during childbirth, what happens is that later on, there can be sclerosis. The joint space will be similar. It will be bilateral symmetrical, a triangular sclerosis. The joint space will be normal. There will be no erosions. And the history will be as I have told you. So this, you remember this for your day-to-day reporting. This, on the other hand, is very important exam fill, hyperparathyroidism. And I'll show you on Saturday better films than this, where there will be other stigmata also of hyperparathyroidism. Now, in hyperparathyroidism, the word mimic, it's a radiological finding, not a pathological finding. So in hyperparathyroidism, what is happening is that there is what we call resorption of bone and subarticular resorption of bone, which gives you this widened appearance of the joint and a bit of a fuzzy outline. Pathologically speaking, it's not sacroiliitis, but radiologically it is. Okay, candidate 4. This case, if you see, has got bilateral asymmetrical sacroiliitis. What is happening in the spine? Can you pick up anything in the spine? Candidate 4.
Yeah, I can see that there is a floating syndesmophyte, which are not marginal, involving the lumbar vertebrae.
What is a floating syndesmophyte?
Which are not marginal and they are not adherent to the joints.
So can I ask you, sorry to cut you, what is a syndesmophyte? What is the definition of a syndesmophyte?
That's the thickened ligaments, and that's the ankle connection of the two vertebrae.
Okay, with this finding and this finding, what is your conclusion?
Yeah, as there is asymmetrical SI joint and the floating syndesmophytes, first differential is psoriasis and less likely ankylosing spondylitis.
Ankylosing spondylitis will show you this finding?
No, but that shows syndesmophyte, but they are like whole of the spine. But psoriasis is my first differential.
Okay, so candidate 4, thank you. I'll mute you, and candidate 5, you be mentally ready. You are next. But let me do a bit of teaching on this case. So in this case, if you look carefully, there was a bit of new bone formation here also. And with that, you can see this bit. So what is this? Now, if you concentrate on this, this is from the New Chapman, and develop your concepts about these terms. Please remember that there is a bit of discrepancy in literature. So you will see the same words being used interchangeably in literature. But I like the concept which is given here, and I want you to follow this, which is given in Chapman. The word syndesmophyte is something else, and the word non-marginal osteophyte, better word, which I found this word more useful, paravertebral ossification. Paravertebral ossification. Now, syndesmophyte can be seen in ankylosing spondylitis, can also be seen in things like hemochromatosis or alkaptonuria, which is this ochronosis. Basically, what is the definition of syndesmophyte? It is ossification of the annulus fibrosus. Look at this epifilm. This is the intervertebral disc. The outermost portion of the intervertebral disc is known as annulus fibrosus. The central portion is known as nucleus pulposus. So when there is ossification of the annulus fibrosus, we use the word syndesmophyte. And when it is bilateral symmetrical and it is involving multiple vertebrae, it will give you that classical bamboo spine appearance. So use this word syndesmophyte for this finding. On the other hand, paravertebral ossification. What happens? Bulky asymmetrical ossification of paravertebral tissue, which may connect with the sides of the vertebral body, but is separate from the margins of end plate and disc. So if you see here, this thing is paravertebral ossification. It can be connected to the body here. It can also connect like this. It can bridge like this, body to body, but it is not arising from the intervertebral disc. So when will you see this paravertebral ossification? You will see it psoriatic arthropathy and chronic reactive arthropathy. Sapho, I believe, is slightly beyond 2B, so I'll not teach you Sapho. But these two, you have to remember. So we'll come back to this entity later on. Now, if you see here, this in the case which we saw here, look at this. This is maybe attached to the vertebral body. It is going here, but it is not arising from the annulus. So other examples, look at this example where this is the vertebral body and this is the paravertebral ossification, which is attached here and attached here. There is another one here. Please remember, sometimes they can bridge together, but don't confuse it with syndesmophyte. Syndesmophyte will be here, number one. Number two, syndesmophytes will be at multiple levels and they will be quite symmetrical. So this is how you differentiate between, so this is paravertebral ossification and paravertebral ossification. And this is a bridging type of paravertebral ossification. You see, it has bridged. And initially you think, oh, is this bamboo spine? Then you look here, there is nothing. Look here, there is nothing. So this can be either CRA or psoriasis. Now, take home point, this is an extremely important concept, exam concept for you to remember. On this side is CRA, on this side is PSA. Look at the difference. Spine and SI joints, there is no significant difference. The difference is in the distribution of hand versus feet. If it is hand involvement, call it PSA. If it is feet involvement, call it CRA. Please remember, that does not mean that hand or feet are not involved in, vice versa cases. Having said that, more common is hand is in CRA and more common, more common hand is in PSA and feet in CRA. Okay. Candidate number 5, can you raise your hand, please? Candidate 5, can you hear me, please?
Yes.
Okay, I have given you, this is one side, this is other side. It's a very important exam film, very subtle findings. So can you take over? What are the findings and which side is abnormal?
So these are lateral radiographs of the calcaneum of both feet of a skeletally mature patient. There is an asymmetry between the two, with the calcaneum displayed on the screen's left having generalized increased lucency with a reduction in the visibility of the trabecular pattern, and at the superior aspect, at the insertion of the tendo Achilles, there's what appears to be some osteopenia.
Excellent. So which side is this? Is the abnormal side?
Yes, I would say so.
Okay. So if you look carefully, all of you, very important for the exam because the findings are subtle, and this is what happens. I have showed you cases before where there was new bone formation here in the new bone formation, as that was slightly advanced case. Now in early case, what will happen? There will be erosion. Look at this outline and develop your eyes on this crisp and sharp outline of calcaneum. You will agree that that crisp and sharp outline is gone, and then there is a bit of erosion here. So, and later on, as the disease progresses, there will be proliferation of new bone or ossification. This is the dendo-Achilles insertion. Okay, candidate 5. This is your next film. Over to you.
Okay, so again, we have lateral radiographs of the foot calcaneum, a DP radiograph of the forefoot, and then a coned-in view of the lateral forefoot of a 35-year-old male with joint pain. There are abnormalities at the posterior superior aspect of the calcaneum where there's fragmentation and erosion. And then looking at the fifth metatarsophalangeal joint, there's relatively preserved joint space, but there are just juxta-articular erosions bilaterally, I mean on both sides of the joint rather than both feet, which aren't shown.
Conclusion.
So the features would be in keeping with an erosive arthropathy with enthesitis, and I would consider reactive arthritis as the number one diagnosis.
And what is your differential?
I think seronegative arthritis are possible.
Okay. What about RA, as in rheumatoid arthritis?
It's a relatively unusual patient for RA. I suppose I should mention that the bone density is preserved.
Okay.
Apart from obviously the eroded parts.
Okay, excellent. If we have a debate about RA, please remember, how can you explain this finding? Basically, there was an erosion here. Then there is new bone formation, right? So new bone formation is not like this. Please remember that this is also a site of RA, but it is slightly unusual in RA. But proliferation of new bone is the answer to the question. Otherwise, your differential was absolutely spot on. This is CRA. And the only thing to this will be PSA, but less likely because of the foot involvement. This is spot diagnosis 30 seconds. What is your diagnosis? Don't give me the description. Okay, you can take it.
Is this CRA from youth? That's
CRA. What else? Why do you say CRA?
Well, there just seem to be prominent degenerative changes that I wouldn't expect in a 45-year-old male, but again, with preserved density. In fact, there's increased sclerosis.
Okay.
Well, there's also prominent enthesopathic.
Excellent.
For example, at the underside of both inferior pubic rami, at the inferior and superior iliac spines bilaterally. I would like to assess the SI joints, but I can't see them very well.
Excellent. So what is your conclusion?
So I wonder if the reason I can't see them is because they're quite severely diseased.
What do you mean diseased?
As in there's erosive process occurring at the SI joints bilaterally.
But if there is erosive change at this point, you will see the joint space, isn't it?
That's true, and I can't appreciate the SI joint space.
So what does that mean? And you know the answer.
They're fused.
Yeah, here you are. They are fused. So this is what happens. When we use the word that in seronegative arthropathy there is new bone formation. This is what happens. Initially there will be erosions, and then there will be new bone formation, and the joint space will be completely filled up. So there is ankylosis of the both SI joints. That is the key here. And with that, there is enthesopathy. So because this is bilateral symmetrical, Eng-Spawn will be up there as your number one differential diagnosis because it's bilateral symmetrical.
Yeah.
So this is the distribution of Eng-Spawn, and this is what happens. This is the annulus fibrosus, which happens. It will be symmetrical. It will be multi-level, and this will give you a bamboo spine. Look carefully. You see, look at this. This is involved. Look at this. This is involved. And remember, in paravertebral, even bridging type, it was like this. PSA or CI. So do use the word Syndesmophyte for this entity, and not this one. So this is a Syndesmophyte, and this is paravertebral ossification. If the candidate 5, if the rheumatologist send this patient to you, rule out Eng-Spawn, how will you report it?
So this is a single coronally oriented fluid sensitive MRI sequence through the pelvis. There are areas of increased signal intensity which appear to represent marrow edema on both sides of the SI joints, the inferior aspect of the SI joints bilaterally, and therefore I suspect that these represent active Sacroiliitis.
Okay, well done. Now, for seronegative arthropathy, the rheumatologists, they advise a lot of MRs. We call it spondyloarthropathy protocol, or whatever your department wants to call them. Basically, what we do is, and all of these are 2A as well as 2B questions, what I'm telling you. For 2A people, these are usually asked. Basically, for that, we do T1 and stir sequence. Through the SI joints, what we do is that we do coronal and axial T1 and stir sequence. Similarly, we do whole spine. And in whole spine, we do T1 and stir sequence. Now, what happens is that T1 is a very good sequence to look for marrow, and it can, things like erosions, etc., are well seen. But stir is the king sequence as far as bone marrow edema is concerned. Bone marrow edema, if you find bone marrow edema, that is diagnostic, for spondyloarthropathy, and this is the criteria from the British Rheumatology Society also. And you can grade it. At a FRCR level, nobody is asking you to grade it. But these concepts are very important. So you can see that on stir, there is high signal. And then sometimes they will also, for disease modifying treatment, etc., they will send you MRs to tell them if there is active disease or not. And the definition of active disease is high signal on stir. So this is the take-home point. Now, this is a case of Eng-Spawn. Over the years, you can see how there is ankylosis, and you can see that there was an IUCD. Now there are tubal ligation clips in the same patient. So this is just to show you how. Now this appearance of the joint, you can see a bit of erosions here. Joint space is irregular. It has got fuzzy outline. Otherwise, it's a crisp outline. Look at this erosion. Look at this erosion. And then when new bone formation, which is a hallmark of seronegative arthropathy, then there is ankylosing spondylitis. Now on this film, candidate number 5, what is the take-home point? Describe it for me. What is happening here? What is here?
So those are focal views, T1 and T2 weighted MRI sagittal, and that vertebral body, which looks thoracic, probably has an abnormality at the anterosuperior corner, which is T1 hyperintense and T2 hyperintense. This is consistent with a Romanus lesion, which I think is the MR equivalent of the plain radiograph shiny shoulder corner, which is maybe the earliest signifier of spine disease and seronegative arthropathy.
Right. So this sign is asked in the exam. This is very important. What the concept behind is that we have got an anterior longitudinal ligament going along, and there is inflammation adjacent to it. So at the corner, anterosuperior or anteroinferior corner, you can find this abnormality. When there will be initially there can be edema there, and at that time T1 will be low and stir will be high. And another point to remember is that this is stir. Now you have to develop your eyes to say that this is a stir sequence, and this is not a T2 weighted sequence. There is a bit of difference there, and you can easily, if you see on your packs and see how a stir looks like and a T2 looks like, look at the cord, look at, this is always a fat saturated sequence by definition, so there will be no fat. So this is a stir sequence. Now, if you see what will happen, that initially when there will be active inflammation, it will be high on stir. Later on a T1 weighted sequence, it might produce fatty marrow, which will be high on T1, and then on stir sequence, the signal intensity can decrease. So in this particular case, there are some acute over chronic type of findings here. Now, this is another case of, edema, anterior. One point for the exam is extremely important. Please remember the distribution. Other than the vertebral bodies, Romanus lesions can be anterosuperior, posterosuperior. They can also be posterosuperior or inferior. But please remember the posterior elements. Posterior elements, edema, you have to pick that up. And if in your case there is edema and you pick it up, the examiner might give you, half a mark extra. And also please remember costovertebral joints. I'm not showing you because of the time factor, but costovertebral joint, of course, can be involved in ankylosing, and particularly on axial, examiner might like to show you. On a plain film, early signs, squaring means that there is deposition of new bone anteriorly under the anterior longitudinal ligament, will give you this square shaped vertebra. So we call it squaring of vertebral body. In this case, there is generalized osteopenia, but that is due to disuse. Okay, we will continue. I'll come back to the break in a while. We will continue for another 5-7 minutes, and we'll come back for the break. Now, this is the equivalent on a plain film, shiny corner sign. So basically, when there will be early disease, active disease, you will not get you can get this kind of a finding, similar to what we saw on MR. And again, you can see that there is squaring of vertebral bodies. So examiner might show you. When you pick it up, look at the facet joints, and look at this facet joints, slightly fuzzy outline, and maybe there are changes there also. And just to complete, there is a lesion, we call it Anderson lesion, which is similar to Romanus lesion, but it involves the intervertebral disc. So the inflammation is at the end plate, and this lesion is known as Anderson's lesion. Same concept. And another example of posterior element, high signal. And X-ray of advanced case, completely ankylosed. These Syndesmophytes. Look at the facet joints. They are also, posterior elements are ankylosed. And when you see an MR axial, all facet joints are completely ankylosed. Similarly here also. Very, very, very important and good case for your exam. Over to candidate 5.
I'm presented with frontal and lateral radiographs of the lumbar spine of a 57-year-old male. There is ankylosis of the sacroiliac joints bilaterally and an extensive spinal ankylosis with syndesmophyte formation, causing the appearance of a bamboo spine. In the lateral radiograph in particular, it is evident that there's a transverse lucency passing through one of the syndesmophytes, which appears to be in the lumbar region. And especially in the context of trauma, which might be minor, I would consider that there may be a fracture and have a low threshold for CT.
Okay, very good. Now, if you see here, the concept is in a bamboo spine patient, candidate 5, you can mute yourself. Your Viva is finished. Candidate 6, be ready now. So now, if you see here, what happens is in this bamboo spine, a trivial trauma, because there is no flexibility, can cause a fracture. And this fracture can go through the intervertebral disc, which is ossified, and it can go through the posterior elements here. And you can see that how significant amount of injury it can cause, actually spinal cord injury, a trivial trauma. Look at this CT scan of another case, which shows you the same thing, which goes here and goes through the posterior element. So I've seen one case in my clinical practice where it was seen on a CT chest, abdomen, and pelvis, but missed because nobody thought about it. So the patient had some trauma, and we did a CT chest, abdomen, and pelvis, and there was this fracture, but we missed it. Now, in inflammatory bowel disease also, similar findings of seronegative arthropathy can be seen. And if you can see that there is sacroiliitis bilateral, these kinds of films are very important for your long cases and for your exam cases, for your story cases. For example, in the exam, they have shown a barium enema examination with sacroiliitis on the same film. So these kinds of things can also come as a long case. So you have to know that inflammatory bowel disease causes that. Candidate 6, if you can raise your hand, please. Candidate 6, can you hear me, please?
Yeah.
Okay. Because of time factor, I'll go through them and then I'll ask you a question. This is a T1, stir, axial stir, axial stir, axial stir. On these 3, this is the MR of the same patient as previously, and I've given you the diagnosis, right? What are your findings on these 3 axial sequences?
So on these 3 axial stir sequences, they're through the lower pelvis.
So what is this bone and what is this bone?
So there is a bone edema seen in the right ischium on these 3 images. There's also irregularity of the cortex of the ischium on the right side. And I'm just wondering, with the context of enthesopathy associated with sacroiliitis in this patient, is there any avulsion fracture?
No. Okay, I'll take over. The point is that this is classical acute enthesopathy. What is happening is that this patient you see there is bone marrow edema, there is also soft tissue edema, and which can happen. So this is why I'm showing it to you. If you look carefully, there is actually a perianal fistula. Perianal fistula is a bit too tough for your FRCR exam. But having said that, you can see this enthesopathy. Look here, ischial tuberosity, and there was edema. And what I wanted to show you that soft tissue edema is acute enthesopathy. Okay, fine. Now, this patient presented with dysphagia, and you have done this barium examination. Over to you.
So it's a barium swallow in a patient with history of dysphagia, which is demonstrating a bit of holdup in the esophagus, especially in the lower images shown, fourth and fifth image. Also, in the spine looks abnormal in this patient, the cervical spine, with anterior beaking of the vertebrae, and probably fusion and pseudoarthrosis, cervical spine.
Okay, I'll stop you here. So the learning points here are what you have described. Let's tackle it like this. You have used the word beaking. You have used the word, what else did you say other than beaking to describe?
Fusion of, yeah.
Okay. Let me guide you. If you see this is the vertebral body, this is a vertebral body, this is a vertebral body. Something is sitting anterior to that. And whatever is sitting anterior to that is ossified. You are right that it is indenting the esophagus. So this picture, what comes to your mind? You know, the posterior elements, etc., are absolutely fine. Look at the intervertebral disc; they are absolutely fine.
Yeah. So anterior longitudinal ossification.
What do you your diagnosis then, please?
Ankylosing spondylitis.
Ankylosing spondylitis will cause, you know, that will be Syndesmophytes, which will be just here. This is too big. Okay, I will take over. So if you see here, this is another case, similar findings, but this time in the thoracic spine. I'll come back to this point. If you see here, this is what we call undulating anterior or posterior ossification. Undulating ossification. Undulating ossification of anterior posterior ligament. Now, DISH. DISH is diffuse idiopathic skeletal hyperostosis. And in this, you know, most probably there is more than continuous 3 vertebrae which are involved. One of the pathognomic findings which are described for the thoracic spine are candidate 6. Can you tell me what are the pathognomic findings described in the thoracic spine, exam findings, as far as DISH is concerned? This is a specific question. Okay, and does anything ring a bell with you regarding the aorta?
Yeah, the aorta looks a bit.
No. I'm talking about DISH, and I'm asking you, how does that affect the appearance of a patient of DISH? Aorta, normal aorta. Okay, let me take.
I'm not sure.
Yeah, that's fine. Don't worry. What happens is that this is a case of, your case initially was cervical spine. That is different case. Look at this one. Here there is undulating anterior ossification. You will appreciate that this is more marked on the right side, and on the left side there is none. And this pattern is known. And the hypothesis is that the thoracic aorta, the descending aorta, because it is sitting on the left side, The hypothesis is that because of its pulsation, you don't see it on the left side. So that's the exam answer. Now, please also remember that dish can also cause other kinds of enthesopathy. And it is written in your Chapman also. So this is a case in which this was the picture of dish, and you can again see this whiskering here and ossification here. And if you don't know it, then you will be surprised at what is happening. So this dish can also cause enthesopathy. There is another ossification, which is ossification of posterior longitudinal ligament. And this has come in the exam, so I warn you. Ossification of posterior longitudinal ligament. And this is a classical example of the eye see what the mind knows. And what is written here usually involves cervical spine, most common in East Asians. Most studies came out from Japan actually initially, but later on people realized that it is more prevalent, not just Japan. Okay, so with this background, over to you. What are the findings?
So it's a cervical spine lateral view. I can see the normal cervical lordosis is lost, and the straightening of the cervical spine, normal atlantoaxial distance. However, there is some, I would say, ossification or density projected across the posterior bodies.
Which level?
Especially at the level of C2 and C3. Yeah.
And what is the axis of this? Is it longitudinal? Is it horizontal? I cannot give you the mouse right now, but if you can tell me.
It's longitudinal. It's perpendicular.
Okay, very good.
It's perpendicular.
So I presume you are picking this up. If you see here.
Yeah.
This is the finding, and this is a classical example. The eye see what the mind knows. You know, nobody will pick up. This is something sitting within the. This is the posterior element, so this must be sitting within the spinal canal. And if you see the CT scan, it is horrendous. Where on a CT scan, you can see that there is ossification of posterior longitudinal ligament. And you can well imagine how symptomatic this patient will be. This is the last film, then I'll give you a 5-minute break.
So it's a DP and oblique view of right foot, which is demonstrating a punched out erosion at the first metatarsal and also proximal phalanx of the first digit of a big toe. There's marked soft tissue swelling around it. So the joint space is preserved. There's also similar finding in the fifth metatarsal head. Again, the joint space seems preserved along with some soft tissue swelling. Findings are quite suggestive of inflammatory arthropathy, such as gout.
And why do you say gout?
Because there's a preservation of preservation of the joint space. There's a periarticular punched out erosion, and there's soft tissue tophi around it, which is quite typical of gout.
You know, this finding that the joint space cannot be involved is not a classical finding for gout. In any case, rest of the finding is correct. Okay, fine. So gout, you can mute yourself. I'll just explain this case and then we will give you a 5-minute break. So, but I'll just continue with this. And after the break, it will be candidate 7, please. Now, if you see here, in gout, what happens is that there are punched out erosions with overhanging edges. Key finding, one of the key findings, you have to develop your eyes on this. if you see the margin of the erosion, it might have a sclerotic border. They say that this is the only type of erosion which has got a sclerotic margin. Nothing else in the world will give you this finding. Having said that, so this is the tophi here, which is sitting here. Of course, there can be involvement which goes along the cortex here, but the joint space is also reduced. So this is gout. And other gout, please remember distal interphalangeal joint involvement. And this is why DIP involvement, if you can make a note for the exam, PSA, erosive OA, gout. So this is a known, we know that gout classically involves the first metatarsophalangeal joint, but nobody in the exam is going to show you this type of gout. It is too, easy. So they will show you something else. And unusual presentation of gout, or atypical or slightly uncommon presentation, should I say. Now, so please remember that gout has got preservation of bone density. And this is another example of gout, which is destroying so many joints. And you can see even here, the bone density is normal. You can see at each and every level. And many of the erosions which we can see, for example, just look at this erosion or this erosion, you will agree that there is a bit of sclerosis of the margin. This is another case of gout in which there is, look at this soft tissue tophus. So this is further example of gout. Okay, we stop here and we will take a 5-minute break. Okay, so the last session, candidate 7, if the candidate 7 is with us, can you unmute yourself? Sorry, raise your hand. Raise your hand, please. Candidate 7.
She has raised her hand.
Can you hear me, please?
Yes, I can.
Okay. This is a AP film of the ankle. I'll show you more films. On this film, anything. Ankle joint is normal. Anything else?
Okay, so on close inspection, I can see some linear periosteal reaction.
Excellent.
Involving the distal diaphysis of the femur.
And then you've got the other side also.
On the other side, it is more extensive than what I saw before. So there is quite visible periosteal reaction, which is involving the distal diaphysis of the femur, and also I can see along the fibula as well. And it is
the tibia you meant, isn't it? Tibia.
Sorry. Yes, sorry, fibula. And then it is very linear with layering, like onion skin kind of appearance, involving both sides. However, the distal epiphysis is spared, and I do not see any changes in the joint space. So, considering this is bilateral symmetrical periosteal reaction, which involves the end of the long bones. In an adult patient, so my differential diagnosis would include hypertrophic osteoarthropathy. I would consider pachydermoperiostosis, but that would be clinical as well, and thyroid acropathy, but that less commonly involves the long bones and is more pronounced in hands.
Okay.
Other differential Sorry,
I'm cutting you because of the time factor. Well done. What will you do next?
So considering that my top differential would include hypertrophic, so I would be seeing the clinical history and any previous imaging available to see if the patient has got any underlying lung condition or abdominal condition which can result in this kind of periosteal reaction. So I would
suppose you have not found anything on the previous exam. What will you do? What will you ask for?
A chest X-ray.
Okay, the point is that your differential in periosteal reaction is HOA, and vascular insufficiency, particularly let's say in venous insufficiency, that will be localized. Here it was bilateral symmetrical. So it can be localized on both sides also. Thyroid acropathy, of course, clinically, and the bones which are involved are usually hands. Pachydermoperiostosis have got quite a similar type of picture, but this is a familial condition and also known as primary HOA in USA. And these patients will be young patients, usually teenage. Fluorosis and hypervitaminosis, of course, has got different radiological factors. Now, this thing is where the problem is. HOA, you have to have a clear-cut idea about the causes. And please remember that initially we used to call it hypertrophic pulmonary osteoarthropathy when we joined radiology. This is how we used to say, and later on we were told not to use that term because it's not just the pulmonary conditions which cause it. In your book, it is divided into primary and secondary. Primary is pachydermoperiostosis, and this is familial. Secondary, most common, lung cancer, bronchiectasis, lung metastasis. With this background, please remember whenever you find this kind of finding, you have to investigate further to rule out. And the top thing is to investigate, do a CT chest, abdomen, and pelvis. That's the answer. I will do a CT chest, abdomen, and pelvis. Now, if you see the less common causes, among the less common causes, you have got so many. And pleuropulmonary causes, pleural fibroma, rare but has the highest incidence, mesothelioma, COPD, fibrosis, sarcoidosis, chronic infection like TB, etc. Now, what is the now? Think like an examiner. With this kind of conditions which can cause HOA, they can show you anything in the exam. And they can also show you a long case. And you have to correlate. For example, if there is a patient with TB on CT scan, and with that HOA, your final conclusion or unifying diagnosis will be simple. On the other hand, if you don't know this, you will be then going in the wrong direction. So that is the main point to remember. So think for long cases also, this can happen. And in GI or disorders, various things like Whipple's, etc., celiac, etc., can all have this. IBD can have it. So all of these are important for you to consider. This is a case from StatDX, which is that this patient presented with bilateral periosteal reaction. This is next to the femur. The joint is normal. They did a CT chest and the patient had a lung tumor. So that's the key point to remember. HOA can also involve the short bones, and here radius, etc. is involved. So this is pachydermoperiostosis, and the key finding is this is what we call primary HOA, that this is a 19-year-old male, and these are familial. And look here, look at this periosteal reaction along the short bones, and so here also long. I don't know much about nuclear medicine, so we have got a separate course on nuclear medicine. And please remember that HOA has come in the exam as a nuclear medicine case. And this is where they start. Your eyes have to be developed to pick up periosteal reaction. You see something like this on a nuclear scan. And the key thing will be that you will ask that I want to see a plain film. This is what they are looking for. So nuclear scan for HOA or is very important. Okay, candidate 7. This case has got periosteal reaction. What do you think is the cause?
So periosteal reaction, which involves the lower legs. I'm still like because this is unilateral. I don't have the other side, so I.
Other side had similar findings.
Okay, so it is bilateral and symmetrical. So it can be HOA as well, but then it can be vascular insufficiency related to deep venous thrombosis disease or varicose veins. It can also be.
You see any stigmata on this case?
There are vascular calcifications that I can see.
So conclusion?
So it will be related to venous insufficiency.
Excellent. So if you see here, this is a very dilated or thick type of a vein which has got calcification, and this case was because of venous insufficiency. So this comes in this second category, vascular insufficiency. Okay, now I will describe this to you, and then I will take you to another film. Now, in this case, you have got this soft tissue calcification, right? And then you have got a hand film, and on hand film, you have got soft tissue calcification. And then you have got this barium examination. So you've got 3 films as a long case. And over to you. Describe this film and what is your conclusion?
So I'm describing this barium film or the previous ones?
So previous ones, you remember that there was soft tissue calcification around the knee.
Okay,
soft tissue calcification around the digit, and with that, this is your third film.
Okay, so this is one of the spot films of barium enema. In this one, on background, I can also see further soft tissue calcifications around the bilaterally in the pelvis region, laterally around the iliac crests. So that further shows more soft tissue calcifications. On the barium, I can see some changes within the fold pattern, I would say.
What's happening in the transverse colon?
So the folds are thickened and they are more widely spaced.
There is a specific word for these.
So yes, that is stacked coins or are something like that.
Anything which comes to your mind with this soft tissue calcification?
Can it be scleroderma or systemic sclerosis?
Right, very good. And what do you, in scleroderma, what happens is, and we will learn it in our GI, that soft tissue calcification, here we are doing differential diagnosis of soft tissue calcification. So this is the close to the last part of the chapter. And with that, you can get pseudo sacroiliitis in the the large bowel. We will come back to this when we'll do our GI. So hindbound, bound gut type of a thing. So this is scleroderma. Now, look at this from your book. Now I'm going into soft tissue calcification and 1 or 2, things there, and then we'll close the chapter. Soft tissue calcification. Look at these 3 words. It should be in your mind. What is this? Dystrophic calcification, metastatic calcification, and there is a specific entity which we call tumoral calcinosis. I warn you, you have to remember this for differential diagnosis of 2 films which come in the exam again and again. So that's why I have highlighted this. Now, dystrophic calcification has got all of these things, and metastatic calcification means, what is the definition? This is from Chapman. You can read it from there. Dystrophic calcification means calcification in abnormal tissue with normal calcium metabolism. And metastatic calcification is usually seen with hyperparathyroidism. Tumoral calcinosis is a specific condition important for differential diagnosis in the exam of very significant lobulated calcification. This is a particular condition which is rare. It is autosomal dominant, usually in Afro-Caribbeans, where you see well-defined lobulated calcifications overlying the external surfaces of large joints, and sometimes fluid levels can be seen. So I want you to remember this. Another case of scleroderma, where in scleroderma what happens is that there is atrophy of the skin and which is calcified, and this is what you see here. Okay, with what I considered in the differential in the previous case, how will you tackle this? What is your differential now? Can you describe and give me your differential? And this is very important for the exam. It has come many a times.
So this is X-ray pelvis with the upper legs showing extensive exuberant calcifications of the soft tissues bilaterally around the hip joint and further just below the right pubic bone as well. Underlying bones seems normal. So my differential diagnosis for these exuberant bilateral calcifications would include scleroderma. I would also include hyperparathyroidism. Tumoral calcinosis, less likely because it's bilateral and symmetrical. Myositis ossificans, but that is not, like most of the times, bilaterally symmetrical.
Okay, that's fine. So yeah. If you see here, this calcification is, very significant amount of calcification overlying joints, and it's not like the finding is quite significant. And this type of calcification, 3 differentials should be in your mind. One is vitamin D toxicity. Second thing is renal osteodystrophy, which is secondary hyperparathyroidism. And third thing is tumoral calcinosis. And tumoral calcinosis, as you have pointed out, will be unilateral. Otherwise, if you find this kind of exuberant calcification, think in these differential. This is again vitamin D. This is an tumoral calcification, calcinosis, and this patient is a Afro-Caribbean 28-year-old right hip mass. So these 3 you have to remember. Another one from literature, usually around the large joints. And this is a CT scan, lot of calcification, incidental in a renal osteodystrophy or secondary hyperparathyroidism case. Spot diagnosis, what is it?
Ochronosis.
Ochronosis.
Intervertebral disc calcification, which has a differential.
Intervertebral disc, or you mean to say the cartilage?
Cartilage, yeah. So the ossification is at the place of intervertebral disc, but basically it is the hyaline cartilage. So it has a differential diagnosis that does include alkaptonuria.
So, this is knee joint, and knee joint, alkaptonuria, definitely you can keep it. But the point is that in knee joint, CPPD should be up there, calcium pyrophosphate deposition disease.
Okay.
And in knee joint as well as in the wrist joint, this is quite pathognomic. Now, calcification of articular cartilage, we call it chondrocalcinosis. CPPD, you have to remember this, particularly in wrist as well as in knee. This is a CPPD case in shoulder joint. Over to you.
Okay, so this is X-ray lumbar spine, AP and lateral views. There is abnormality involving almost all the vertebra, with most significant at the level of intervertebral discs. Marked sclerosis is seen within the disc and around the superior and inferior end plates, resulting in narrowing of the intervertebral disc and joint spaces. And on the AP film, there is
anything here. What is this where I'm pointing out? What is here?
So there is sclerosis at the superior and inferior end plates.
In between the sclerosis, for example.
In between the sclerosis, there is also calcification of or ossification of the intervertebral disc.
So here you are, again, calcification of intervertebral disc. What will be your differential, 36-year-old?
It will be like in ankylosing spondylitis, but no, this is not the age, and other findings as well. I can have the alkaptonuria or ochronosis as a differential in this.
Mm-hmm.
For the ankylosing spondylitis.
Okay, good. We stop. Now, the point is that this film came to one of my students years ago, and this is what we call intervertebral disc calcification, intervertebral disc calcification. And the most common causes are these ones, and less common are these. And the examiner just went on and on and on. And this can happen. We call it, in the exam, we call it discussion cases, where the examiners want to see your thinking. And my experience is that many a time these kinds of cases come. When I get a feedback from the students, they are not very sure if they have been able to satisfy the examiner, and they might have done very well. The point is that they are actually checking your thinking and the rationality. What is it? There might not be a specific diagnosis. Now, this particular case is 36-year-old, intervertebral disc, and lot of degenerative cases. Changes. So if I don't have time to go into details of all of these, but having said that, if you start, having a debate, what can it be? And believe me, in a 36-year-old, because this is what is happening in the exam, this film, this sex, this age, this is what they want to talk. Why is there so much degenerative changes? And why is there disc calcification? And alkaptonuria will be up there as the diagnosis. And other things you can rule out because of X reason or Y reason. So this is the type of thinking you should have. In alkaptonuria, what is happening, that this is a disorder of tyrosine metabolism, and homogentisic acid is deposited in the spine as well as other joints. There is a bit of overlap with CPD also at times, but spine is more commonly involved. So now we go to candidate, thank you, candidate 7, and we go to candidate 8. Is candidate 8, can you raise your hand, please? No? Okay, let me see. I can. No, I cannot see candidate.
Did they change the name to the...
Okay, now candidate, because I cannot see candidate 8, sorry for that. Candidate 1, are you with us? You want to have another go? Okay, let me see who.
Hi.
Candidate 1, you are with us, okay?
Yep.
So now, what do you think is happening? Over to you.
So this is a radiograph of a knee in a 37-year-old male patient. There appears to be bone destruction, degeneration of the internal joint, loss of joint space, debris with increased density of the bone. My primary diagnosis would be a Charcot joint in the knee. My differential would be previous septic arthritis of the knee. I would correlate with the other side to see if it's a unilateral process or bilateral, but and if there's any sort of history to account for this appearance.
What is the bone density?
So I think the bone density is preserved.
And your differential was septic. What did you say?
Charcot joints. Charcot.
And the differential other than Charcot's?
Previous septic arthritis of the knee, but I think it's unlikely.
Okay.
Probably Charcot would be my first diagnosis.
Okay, that's fine. Now, the point is that in Charcot joints, remember the 5 Ds. Increase bone density, distension as in effusion, bone debris. So what happens is that the bone is, cut into pieces, cartilage destruction, and joint disorganization. These are the 5 Ds. And in this, so there is nothing else which can explain this finding. Remember the word bizarre. When you see a joint which has got bizarre appearance, think Charcot. And it cannot fit into anything. Please remember the bone density will be normal. So this is a case of tertiary syphilis, which has got this. This case, on the other hand, we can see, candidate 1, just give me the diagnosis. It's a very easy case.
Charcot of the foot.
So what will be the cause?
Diabetes.
Diabetes. So if you see here in diabetes, there is a what we call a Lisfranc dislocation, and you can see that this is a rocker bottom foot also, and these joints, the mid-tarsal and the tarso-metatarsal joints are involved. Easy case. This is what happens in diabetes 91 and in 92. What has happened that you see how there is sclerosis and there is destruction and debris in the joints. This is another Charcot. This is a very nice film. Over to you. How will you describe this? This is a classical 2B film.
Radiograph of the right shoulder in a 35-year-old male. There is bone destruction, increased sclerosis, and debris within the right glenohumeral joints. There's also expansion of the joint space. Findings are in keeping with a Charcot joint of the right shoulder. My next step would be to image the spine to exclude the syrinx.
Excellent. Now, in this particular case, the key thing is that if you open a textbook and read a Charcot joint, they will say, you remember the word bizarre. So it is, and they say that sometimes the bone edges will be seen as if they had been cut surgically. So like this case, nothing else can explain this. And so there's a bit of debris. Look at the glenoid, everything is abnormal. In this kind of case, you will advise MR because in shoulder, usually it is look for a syringomyelia. This is not the same case. This is a different case, but this patient also had a syringomyelia. But just to elaborate that this is a syrinx which can be symptomatic. Okay, candidate 1, over to you.
So this is a radiograph of both knees, tibia and fibula and foot. So there's complete deformity of the left knee joint, which has a bizarre appearance with increased sclerosis and expansion of the joint. There's also destruction of the talotibia joint on the left hand side. The right joint appears to be preserved. with no abnormality on the right-hand side. So in summary, this looks like the patient has Charcot joint in the left knee and left ankle, and there's also increased sclerosis in the left tibia on the medial aspect with some irregularity. In a 13-year-old female patient, my top differential will be congenital inability to feel pain.
Okay, so if you see, this is a, there is an entity, we call it congenital indifference to pain. These children do not feel any pain, and they jump from heights. They show off, actually. They might jump from the first story and show off to their peers. And you can see what has happened, that there is ankylosis, complete deformity on the other side. This is the other side because that knee is normal. This knee is, so this is congenital indifference to pain. Quite a pathognomic condition, but the only thing is that this disease should be in your vocabulary. You should know this. Spot diagnosis, what is this?
So there's some calcification.
Be ready. If you are there, I'll ask you to show hand after this case.
Is it cystocirrhosis? Is that what this is?
Say again, please.
Cystocirrhosis?
No. If you see here, this is a young patient.
Sorry. Osteochondromatosis.
Osteochondromatosis. So, you can please mute yourself. Candidate 2, can you hear me, please? No. I think there is a technical issue there. I cannot unmute. So, because of time factor, I believe we will continue. Now, what is happening here is, this is synovial chondromatosis. What happens in synovial chondromatosis is that there is metaplasia of the synovium. So there is cartilaginous change in the synovium, and then it gets calcified and it can divide into hundreds of pieces, and it can then go into the joint space. All of these are loose bodies, and because these are loose bodies, they can cause secondary OA. These patients are always young patients. Please remember that. So they might be 20-year-old, and then there will be secondary. Look at this. Epiphysis is even not closed. Synovial chondromatosis. It's a aunt mini case. Osteochondromatosis or chondromatosis, whatever you want to call it. So candidate 2, can you raise hand? Three, can you raise hand? Okay. Something is wrong.
Hello?
Now, number 3, are you with?
Yes.
Okay. So I could not unmute number 2. Sorry for that. Now, this is an extremely good exam case. So concentrate on this. This is closer to 9, but please concentrate. Very, very good exam case. Over to you.
Okay, so this is a frontal pelvic radiograph of a 22-year-old female. I can see the abnormality is centered over the right femoroacetabular joint with multiple punched out lytic lesions with sclerotic. Some of them are showing a sclerotic margin on both sides of the joint. I can see.
Excellent. What is your conclusion?
Sorry.
What is your conclusion? Well done. Your description is very good. Because of time, I want to you to give me.
I suspect PVNS, which is hypertrophy, pigmented villonodular synovitis. I think there are outgrowths from the synovium punching out the articular bones.
Okay, so now the point is that this is a very, very good thing. What is the take-home point is, young female, 28-year-old, you have got you have got lytic lesion on both sides of the joint. Explain it. Why is there in lytic lesion on both sides of the joint in a young patient, 22, and nothing comes to your mind? So what happens in pigmented villonodular synovitis? Now, this differential diagnosis is extremely important, and on Saturday, I will revisit this lucent epiphyseal bone lesion. And this is extremely important for the exam. Many a times it will come in the exam, and you should know it very well. And lesions related to joint pathology and in geode, etc., PVNS is there. Giant cell tumor, chondroblastoma, age will change everything. We'll come back to these points. But PVNS. In PVNS, what happens is that there is proliferation of the synovium, and it produces a villonodular mass. And sometimes it goes into the bone, so there is osseous extension. When there is osseous extension, intraosseous extension, it can cause this kind of finding. And number two is that if there is no osseous extension, another point to remember is that it will have hemorrhage inside, and this hemorrhage will be low signal on T2 weighted sequence. So that is another point to remember. Now, if you see here, candidate 3.
Yes.
In this case, there is a, why is this echo? What is happening at your end?
There is joint effusion.
Okay, there is joint effusion in a 23-year-old, which number 3. I'm sorry, I will have to mute you because there is too much echo and causing a lot of technical issues. Is number 5 here?
Yes.
Okay. Now, if you see here, because of the time factor, I'll give you some leading questions. Now, in this kind of a case, what will happen that I am showing you a plain film, and on this plain film, we can see effusion in the knee joint. And the examiner will, once you pick up the effusion, the examiner will ask you what can be the cause. And, trauma, etc., you can debate, is there history of trauma? There is no history of trauma. Young patient, what should be done? PVNS should be in the differential diagnosis. And then comes this MR. What is your finding? Just one big finding I want you to tell me because of the time factor.
There's low signal synovial proliferation.
Yeah. So this is a classical exam case where this is what we call hemosiderine, right? So there is low signal, and which is a bit of hemosiderine, and this is pathognomic in a young age group for pigmented villonodular synovitis. So remember this gradient echo sequence, T2 weighted sequence. will show it as low signal. Another case where there was an intraosseous component, and on MR, you can see that it has gone into the bone. Last few films of the day, and then we are finished. What do you think is this?
So there's these are radiographs of the forearm and right femur of a 57-year-old female. In both the visualized limbs, there's extensive soft tissue calcification in the myofascial planes. I think this is likely to be secondary to myositis given the distribution.
Right. So this is what we call sheets of calcification. If you see a CT, nobody is going to show you a CT, by the way, for this. But having said that, just to develop your concept that it is quite superficial, isn't it? So this is, the differential diagnosis of dermatomyositis, sheets of calcification. Another film. So just to show you an example. Now, myositis is another thing which you can relate with spondyloarthropathy, because myositis comes under the domain of rheumatologist, and they will send us cases where rule out myositis. So these also are viva questions and 2A questions. Interestingly, for a clinical question of myositis, same sequences are done, T1 and STIR. And the concept is that your report, first of all, if there is edema, it will be high signal on the STIR sequence. And once you pick up edema, you have to tell the rheumatologist which muscles are involved. And at times they will like to do a biopsy from that muscle in which there is, just to document the diagnosis. At times they will just go with an MR and clinical findings and might not do a biopsy. So CK, etc. will be increased. So this is myositis protocol. So remember, myositis protocol is like spondyloarthropathy protocol. Candidate 5. This patient has got chronic type of symptoms of myositis. What is the take-home point? What are your findings? So this is right, left, right, left, right, left, right, left. This is STIR, T1, T1. Over to you.
So there's fatty replacement of the muscles in many of the compartments, most notably the posterior compartment on the left and the anterior on the right.
Right. So if you see here, this is a good case to develop your eyes. Changes are quite chronic. So please remember, when there is acute myositis, the muscle is healthy at that point bulk-wise, and there will be increased signal like this. When there are chronic changes, there will be fatty atrophy. So fat deposition within the muscle. And fat will be high on T1 weighted sequence, and it will suppress on the STIR sequence. Within that, when there is acute over chronic changes, high signal will still persist. Look at this quadriceps. It is healthy. And on T1 also it is healthy. This one has got a bit of high signal and a bit of fatty atrophy. So all kinds of abnormalities can be found in this particular case. Last 3 cases. What do you think it is? There is a history of trauma.
Probably hemorrhage then. Hematoma?
What do you mean hemorrhage, this thing?
Well, just there's a sort of ovoid soft tissue mass with some peripheral calcification. If there's a history of trauma, well, okay. So, I mean, it's in my differential that it could be a hemorrhage, because in chronic hemorrhages, they can calcify. Another possibility is some post-traumatic heterotopic ossification.
What do you call this? Myositis ossificans, right?
Oh, yes, yeah.
What I was trying to, here, should I say. Myositis ossificans is a very important exam case. And they might show you serial films also. Myositis ossificans, as the as the word tells you, that because of trauma there might be hemorrhage. And then there is ossification. Key thing to remember that the ossification initially is at the periphery. That's a very good sign. And gradually, if you see the same case after 6 months or 1 year, it might have ossified all of this. So this is a key thing, because these patients can present with a lot of symptoms. If you do an MR, you are in trouble, because MR will give you such suspicious type of findings that you might actually think as if there is something like a sarcoma, etc. So plain film with this peripheral calcification is an exam concept which they want to ask. Myositis ossificans. This is soft tissue ossification, and trauma is one of them. Myositic ossificans. This is a case of paraplegia with ossification, and there are other tumors, etc., which we are going to do next time. Spot diagnosis. What is this?
Cysticercosis.
Excellent. So this is a case of cysticercosis, which has got multiple, these, and this is the calcification, linear and curvilinear soft tissue calcification, and with that, parasites, cysticercosis. Guinea worm is an exam case, loa, and this one. Last case of the day. Can you tell me what this is?
So this is a lateral radiograph around the knee of a skeletally immature patient. There's a serpiginous coiled calcified density posterior to the femur. Generally, these sorts of things can be vascular, but there's no vascular calcification elsewhere, and it just stops abruptly. With the right history in either a tropical patient or travel to that area, I'd want to consider guinea worm disease, Sacroiliitis.
Right, very good. We stop here. You stop here. You can mute yourself, but I'll tell you a very interesting story about this case. This is the last case of the day, and this is an Aunt Minnie case. Aunt Minnie means that either there's no differential, and this has come in the exam, by the way. And please remember, if a patient has got this finding, it will be there, remain there for the rest of the life. And I've seen 2 cases here in Basilar. That doesn't mean an active disease, means historic. So guinea worm is also known as Drunculus medinensis. And those of you who are eating dinner, I want you to stop there in a lighter way. And before I conclude, I want to tell you my personal experience with this. And this is too gross, so if you want to switch off, you can. So guinea worm, Drunculus medinensis, is very interesting. If you Google it, WHO website, guinea worm, it will tell you that people say that even it is, in Old Testament where they mention snakes coming out of the bodies, this is the worm. Can you imagine the cycle? The cycle of this worm is that you drink water which has got this, it goes into the intestine, male and female, they mate, they produce, and the female actually then becomes big. It is up to 80 centimeters in length, close to a meter. Unbelievable. And after a year living inside the intestine, etc., it goes, travels into the muscles. And ultimately, for some reason, they come out from the feet. They come out and then they lay eggs. That's the cycle. It was endemic the world over, this disease. And so this is the study which is published in Lancet in 1996 and 95 actually. And I'm from Pakistan, so I'm talking about Pakistan here because I've seen this disease in Pakistan, and that was 1988. We have got a desert there known as Thar Desert, and I've seen it myself. What happens is that this worm comes out, and when it comes out, unbelievable, because if you pull it, the worm which is inside will remain alive, and it is very painful and things like that. So the technique is that you wrap it around a matchstick, and every day you increase these, take it out more. It might take you 15-20 days to take it out. So it was a horrendous disease, but WHO did very well. And in early 1990s, about 1 million cases were reported in the world. Last year, there were only 28. It has been eradicated in most of the world except for 4 countries in Africa. And the only bad thing is that now it is seen in some African countries more commonly in dogs. So it is still there, but it is more or less eradicated, one of the WHO success stories. So this is guinea worm. And